Hello, and welcome to today's presentation on body mechanics, ergonomics, and MSD injury prevention. This education session is being presented by our staff development team from Celtic Healthcare. After this presentation, the learner will be able to define ergonomics, body mechanics, and MSDs, state causes and at-risk factors for back pain, identify 2 to 3 back injury prevention measures, discuss proper body mechanics with lifting, and review proper transfer techniques. For registered nurses in Pennsylvania, 0.75 CUs will be administered for appropriately completing this assignment. Musculoskeletal disorders, or MSDs, affect the muscles, nerves, and tendons. Examples of MSDs include carpal tunnel syndrome, tendinitis, rotator cuff injuries, which is a shoulder problem, epicondylitis, an elbow problem, trigger finger, or muscle strains and low back injuries. Work-related MSDs, including those of the neck, upper extremities, and lower back, are one of the leading causes of lost workday injury and illness. Risk factors for MSDs include lifting heavy items, bending, reaching overhead, pushing and pulling heavy loads, and working in awkward body postures. Work-related musculoskeletal disorders can be prevented by good body mechanics and ergonomics. Now let's take a look at the impact of musculoskeletal disorders in the workplace. Work-related MSDs are among the most frequently reported causes of lost or restricted work time. In 2012, the Bureau of Labor Statistics reported that industries with the highest MSD rates include healthcare, retail, wholesale trade, and construction. 388,060 MSD cases accounted for 34% of all worker injury and illness cases in 2011. Median days away from work equaled about 12 days in 2011. In 2012, sprains, strains, and tears were the leading causes of injury and accounted for 38% of the total injury and illness cases requiring days away from work. And taking a look at this graph here, about 150 injuries per 10,000 in the state and local government for registered nurses, and about 125 per 10,000 in the private sector. Whereas with our nursing assistants, the rates jumped dramatically. Over 700 injuries per 10,000 full-time workers in the state and local government sector, and then about 400 per 10,000 workers in the private sector were injured. So impact of MSDs in the workplace is great. Some other statistics related to MSDs injuries in the workplace. In 2012, sprains, strains, and tears were the leading nature of an injury and illness and accounted for 38% of the total injury and illness causes requiring days away from work in all ownership, so both private sector and public. The incidence rate was 43 cases per 10,000 full-time workers. Of the 443,560 sprain, strain, and tear cases reported in 2012, 63% were the result of overexertion and bodily reaction. Falls, slips, and trips accounted for another 23%. Workers injured their back in 36% of the sprain, strain, and tear cases. So let's take a look at what ergonomics means and the definition. The term ergonomics is derived from 2 Greek words, ergon meaning work, and nomoni meaning natural law. Ergonomics is fitting a job to a person, helps lessen muscle fatigue, increases productivity, and reduces the number and severity of work-related MSDs. We can significantly reduce risk of injury if we adhere to some ergonomic principles. Those principles include in the workplace All work activities should permit the worker to adopt several different but equally healthy and safe postures. Where muscular force has to be exerted, it should be done by the largest appropriate muscle groups available. And lastly, work activities should be performed with the joints at about midpoint of their range of movement. This applies particularly to the head, trunk, and upper limbs. And how is body mechanics defined? Well, body mechanics refers to the way we move during everyday activities. Good body mechanics may be able to prevent or correct problems with posture. Posture equals the way one stands, sits, or lies. Good body mechanics can also protect your body, especially the back, from pain and injury. Now let's take a look at why you need good body mechanics. Having the body in the right position helps protect the back and allows you to use your body in a safe way. The spine goes through the midline of your back, giving your back stability and controlling its movement. The spine is made up of 33 bones called vertebrae. These bones are stacked on top of each other in a line. The line goes from the base of your skull to your rear end. Shock absorbers called discs are next. The discs lie between the vertebrae and cushion and protect the vertebrae. They are also some movements of the spine, or also allow movements of the spine. Then you have the spinal cord and nerves. The spinal cord sends messages from your brain to the rest of your body. The spinal cord is protected by the vertebrae and is surrounded by the spinal fluid. Also, you have small joints in your spine. These joints allow movement and help to stabilize your body. And lastly, the spine is made up of muscles and ligaments. Ligaments support and strengthen the joints. Muscles and ligaments provide strength, power, support, and stability to your spine. Injury to the spine may cause problems such as loss of feeling, movement, and strength. There may also be problems with the other organs of your body and loss of normal body functions. These functions may include going to the bathroom, swallowing, or breathing. Good body mechanics are important because they will help protect your spine and other parts of your body from injury. When caring for a person who is recovering from an illness, it is important to use good body mechanics. You may need this when helping a person get in and out of bed, into a chair, walk, or just move around the house. You may also need to push a person in a wheelchair or move the person in bed. So, by practicing good body mechanics, that will keep you free of injury.
Back problems occur in 8 out of 10 Americans in their lifetime. Statistics also show that there are more than 10 million Americans off related to back symptoms each year. Back injuries can range from a dull, constant ache to a sharp, sudden pain. Acute back pain comes on suddenly and usually lasts for a few days to a few weeks. Back pain is called chronic if it lasts more than 3 months. An old adage is, an ounce of prevention is worth a pound of cure, and this is really worth its weight in gold when we talk about back injuries. So who can get back pain? Really, anyone. Anyone can have back pain, but there are some factors that do increase your risk. Getting older, and unfortunately we all are getting older each day, but back pain is more common the older you get. You may first have back pain when you're around 30 or 40 years of age. Poor physical fitness is another key factor. Back pain is more common in people who are not fit. Being overweight, a diet high in calories and fat can make you gain weight, and too much weight can stress the back and cause pain. There are some inherited diseases or conditions as well, such as different types of back pain, as disc disease can be inherited. Other diseases or conditions that can affect back pain include some types of arthritis, and cancer can cause back pain as well. We have scoliosis, spinal stenosis. Pregnancy actually can affect your back. Kidney stones, infections, endometriosis, fibromyalgia, tumors, stress. All of those things are factors that could affect back pain. Additionally, your job. If you have to lift, push, or pull while twisting your spine, you may get back pain. Such as the healthcare industry, if you work at a desk all day and do not sit up straight, you may also get back pain. Smoking. Your body may not be able to get enough nutrients to the disc in your back if you smoke. A smoker's cough may also cause back pain. People who smoke are slower to heal, and so that back pain may last even longer. Another factor is race. For example, black women are 2 to 3 more times likelier than white women to have pain in their lower part of their spine and have it slip out of the space. So there are a variety of risk factors. Some you can't do anything about, but there are many that we can. Most healthcare worker-related injuries occur in the lumbar spine or the lower back. The spine has vertebrae, which are individual bones in the flexible spinal column. Now, between each vertebrae is a disc that allows for shock absorption and movement. Spinal cord has nerves that go through the vertebrae to lower extremities, and this provides for sensation and movement. The ligaments hold the bone to bone and reinforce the disc. Unfortunately, the ligaments of the spine are thinner at the place where we need them to be thick and strong. Weakness in the back and abdominal muscles increases that risk of that back injury. Muscle spasms are the most common cause of back pain. Awkward movements of a back can cause muscle spasms. The spasm locks the back, and the spasms can cause severe pain. Spasms can occur from just even tying a shoe or twisting your back to change direction, or twisting while lifting or moving patients, and even from a simple sneeze or cough. Spasms can also occur when heavy lifting is involved and we do it incorrectly. Treatment of severe spasms can include physical therapy and medication. Now, we're going to talk about some common types of disc injury. Remember earlier I said the spinal disc acts as a cushion or shock absorbers. This is a soft center in the disc with a hard, fibrous outer portion. The discs are more like moist sponges. And the older we get, we lose some of the water-like material, and the disc gets more rigid or harder and does not cushion our back as well. This is called disc degeneration or degenerated disc. I'm sure you know people who have this condition, even some of your patients and family members. Spurs are a new bone growth that occur above or below the disc. Spurs can get large enough to cause pressure on the nerve and cause pain, numbness, and weakness down the legs. Herniated disc or bulging disc are very common. They occur within the inside of the disc, starts to bulge out, and changes the shape. The bulging disc then places pressure on the nerves in the back and can cause several leg pain, numbness, and weakness. This is also called sciatica. There are many other disc injuries, but these disc injuries are the most common. Now we are going to look and talk about prevention for back injuries. There are 3 big categories that we will look at: exercise, posture, and body mechanics. Injury prevention exercises include walking regularly, stretching and bending, and doing sit-ups, practice with leg lifts, and practice squatting. All of those things will help with prevention of back injuries. Here are some simple back exercises that are recommended to be done 2 or 3 times a week, again for prevention. You can do partial sit-ups where you bend at the knee, slowly raise your head and shoulder off the floor for about 10 seconds. Knee to chest raise, where lying down, slowly pull your knees to the chest, relaxing off the floor, holding for 10 seconds, and then repeating 10 times. Also, you can do the press-up. Lie down with hands near shoulder and pelvis on floor. Press up painlessly and hold for 10 seconds. Repeat for 10 times. These are some simple exercises for back prevention. Believe it or not, sleeping is an important consideration for preventing back injuries. You should be sleeping on a firm but not hard mattress. Waterbeds are fine if they're adjusted properly. Is there a better position to sleep in? Actually, the research shows that any comfortable position is fine, including sleeping on your stomach. Slouch sitting can very much affect the health of your back. When sitting in a slouch position, what you are doing is increasing the pressure of your body weight on your disc, 150%. Slouching also increases the stress on the ligaments of the bones and spine. Proper sitting includes having an erect spine, correct lumbar concaving, using a towel roll or to get a proper curve of your back. And I actually have started using one of those like airplane pillows with the beads, but they're like a rounded roll type, and it works wonderful. And also to have your head and shoulders retracted and tipped back.
As mentioned earlier, proper body mechanics is another key preventive measure for reducing injury. It's not so important of how much you lift, but how you do it. The next several slides are some steps to help you with good body mechanics. Body mechanics when standing: you should wear shoes. They protect your feet from injury, give you a firm foundation, and keep you from slipping. Keep your feet flat on the floor, separated about 12 inches apart. And also keep your back straight. When walking, keep your back straight as you walk. If you help a person to walk, you may need one arm around the back of the person, put another arm at the side, or ready to help the person if needed. Here are some good body mechanic practices when lifting items. Feet should be apart in a standing position. Keep your head up, chin tucked in, and back arched and straight. Lower your body to get close to the object, and keep your weight close to the body and stand upright. Test the load prior to lifting. Determine if help is needed, and avoid rapid movements or jerking. Some other key practices when lifting for body mechanics: do not lift, bend, and twist in a combination. When turning, rotate your whole body, not just your back. Bend from the hips and knees. Do not bend at the waist. Keeping knees bent and back straight, lift the object using your arm and leg muscles. Do not use your back muscles. If the object is too heavy, ask for help. Push, don't pull objects. Some proper practices when carrying an object: hold the object close to your body and do not carry things that are too heavy for you. Other good body mechanic practices when pushing or pulling items: use the weight of your body to help push or pull an item. Feet should be apart as in the standing position. Keep your back straight. Lower your body to get close to the object, and again, do not bend at the waist, and if too heavy, ask for help. Now let's take a look at some good body mechanic practices while sitting. If you can, sit on a hard chair with your back straight. Put a pillow or rolled towel to support the lower back. When you sit for too long, raise one leg higher than the other to help keep from getting tired. Do not sit for long periods of time. Get up and change positions every so often. When driving, adjust the seat to a comfortable distance from the wheel. Sit back in the seat so your knees are even with the seat. Now let's focus on some good body mechanics for patient care. Caregivers, including healthcare workers, must use good body mechanics to keep both themselves and their patients safe. Always lift using your legs and keeping your back straight. Remember to avoid twisting your back when changing directions. Instead of twisting, move your feet. Take a step to keep your back in good alignment. When working with patients in hospital beds, raise the height of the bed to limit the amount you need to bend to access the patient. Make it comfortable for you. Taking that minute to raise and lower the bed is worth the effort. Always wear safe footwear, especially when working in the bathroom. When the linoleum or tile gets wet, it gets very slippery. Having a safe rubber bottom shoe on will help to keep both you and your patient safe. So how should a patient be positioned in bed for proper body mechanics and alignment of their spine? Let's take a look at positioning a patient on his side in bed. First of all, ask or help the person bend their knees. Put a soft pillow between their knees. Positioning a patient on his back with the bed flat, have them put a pillow under their head. Use a rolled towel to support the lower back, and a small pillow under the calves and ankles may be used as well to help properly align their spine and make them comfortable. Proper positioning of a patient on his back with the head of the bed raised. Put one or more pillows behind the head and shoulders. A pillow may be put under the knees to bend them a little and take pressure off the spine. And you can also add a footboard to keep the feet in place and to prevent the patient from sliding down in bed.
When transferring a patient from a wheelchair, make sure to remove the leg rest before transferring the patient. This is going to help prevent both you and the patient to have to move around those leg rests and will decrease the risk of tripping and falling. Encourage the patient to assist as much as possible with the transfer. This is going to reduce the amount of assistance that you will need to provide. You should not be lifting a patient who is able to help you. My father-in-law was recently in the hospital and then in a skilled nursing facility. He was over 350 pounds. He became bedbound in just 2 days after being in the hospital, and it required 4 to 5 people to lift him to get him out of bed, and they had to use a very large lift. Well, we had difficulty in finding a skilled nursing home that would accept him because of his weight and his inactivity status from the hospital. The comments and expressions upon the admission was a lot of concern about moving him, and the therapy worked with him, and in just a few days he regained enough strength that he was able to significantly assist with transfers and movement. He was able to regain all of his strength more and more and was able to return home to be fairly independent. This one male nursing assistant even laughed at his first impressions, but using proper body mechanics, walker, and encouragement to my father-in-law, they were able to complete the lift, and the aide ended up only needing to provide 5% of assistance to getting him in and out of bed. So tell your patients what you need them to do and work as a team. Always ask for assistance if you need. You are not Wonder Woman or Superman. If you think you might need assistance, then ask for help. If you find that it was not that difficult, then the next time you can move that patient maybe on your own. But offer help to peers too to save their backs when you know there might be a difficult situation. And even for the office staff, if there is something heavy, offer assistance. There are 4 basic transfer types: sit-to-stand transfer, stand-pivot transfer, supine-to-sit transfer, and bathtub transfer. Nearly all transfers completed with a patient will fall under one of these categories. We will review each type of transfer in detail. The sit-to-stand transfer is the most frequently used transfer type. If the patient is able to bear weight and stand with assistance or alone, then you will use this transfer type. This transfer is moving from the seated position to a standing position. Some patients require verbal cues to achieve this transfer successfully. Many people may forget to complete a step or need assistance with you giving them some physical assistance or verbal reminders to help get them up. Instruct the patient to scoot forward onto the edge of the chair, the bed, etc. If assistance is needed, you can provide this by having the patient lean towards the left, pull them to the right side forward, then lean them to the right and pull the left side forward. Repeat this as necessary, wiggling their way forward. Next, instruct the patient to move their feet back and lean forward. The head of the patient must be over their feet for success. The patient should use both hands to push up from the surface that they are sitting on. Once they are in the standing position, they can place their hands on the walker. Many individuals will try to reach and pull up on their walker. This should not be done, as the walker can tip over and the patient could fall or become injured. This step often requires reminders to place hands on the chair. Your positioning is very important for the success and safety of a transfer. You can also provide different levels of assistance based upon the patient's need. Most patients will be easily assisted by standing beside the patient with your hand closest to the patient, placing it around the patient's back, and your opposite hand placed on the patient's near shoulder. This positioning ensures patient safety in both forward and backward direction, where you can provide slight assistance if the patient loses their balance. I'm going to repeat that again. How you would stand is to put your hand closest to the patient around the patient's back and your opposite hand on the patient's near shoulder. Some lower functioning patients, those that may require more assistance to move them from the seated position, put them in front of position yourself in front of the patient and lift slightly. This technique on a case-by-case basis. The preferred way is from the side. A gait belt is a canvas or vinyl coated belt that is placed snugly around the patient to provide a handhold for the caregiver. Now, this can be used for patients who are lower functioning or those that have an increased risk of falls. So how do you use a gait belt? You need to explain the procedure to the patient and caregiver about what you're going to do. Assemble all your equipment in a convenient work area. Now, here are the steps to apply a transfer belt around the patient's waist, or you can be using to teach a family member to do using the gait belt. Put the end of the transfer belt into the toothed side of the buckle. Fasten the transfer belt securely around the patient so the belt does not slide up the patient's body. Stand in front of the patient. Place your hands under the patient's body and gently slide him or her to the edge of the bed or chair. Reach around the patient and grasp the transfer belt at the back with the thumbs and fingers pointing up. Assist the patient to a standing position according to the proper procedure for transferring and body mechanics. While holding the transfer belt, allow the patient to stand for 20 or 30 seconds until he or she feels balanced. Using the transfer belt, pivot or turn the patient to the bed or chair. Use body mechanics and gently lower the patient into the bed or chair. Remove the transfer belt from the patient. Provide any comfort measures needed. Clean and replace equipment according to our standard precautions. So if it becomes soiled, it's going to need to be cleaned, and you follow our policies. Do not forget to document that you've used the gait belt in your notes. That's significant to show the amount of assistance that the patient is requiring to safely ambulate and also to prevent falls. A stand pivot transfer is a basic sit-to-stand transfer, followed by a small turn or pivot to sit on another surface. The transfer is often used for wheelchair-level patients that can only stand for a very short period of time. The transfer surfaces, like a wheelchair and a bed, should be placed next to each other as close that you can get them, and ideally there should be a 45-degree angle between the surfaces, with the surfaces slightly angled towards one another. For example, a patient uses a wheelchair to move from the bedroom and now needs to get into bed. The wheelchair should be placed directly next to the bed and angled slightly towards the bed, so there is no open space between the bed and the closest corner of the wheelchair. Now, if space is limited or you're unable to place the wheelchair at that angle, the chair can be placed directly beside the bed with no space. The primary goal for this transfer is to minimize fall space, so protecting the patient from falling. The caregiver can stand beside the patient as earlier reviewed in this session, or sometimes the patient may require the caregiver to stand directly in front of the patient, facing the patient. Total joint replacement patients have special considerations due to the severity of their surgery. All total joint patients should avoid pivoting or turning on that planted foot, the foot that's not moving. Small steps are preferred, the method in this case, so that they would be small steps in turning rather than putting all their weight on that planted foot. The supine to sit transfer is moving from a lying position where the patient is on his or her back to a seated position at the edge of the bed. Now there are two techniques to achieve this transfer. The first technique is to have the patient roll onto their side, which is closest to the bed. You could stand directly beside the bed for safety to be sure the patient doesn't roll too far. Once the patient is on their side, the patient can move their legs forward and off the bed, propping themselves up on their elbow and then pushing to the seated position. The second technique is what's often used with supine, laying down, or sitting transfers that does not require rolling. The patient moves their outer leg towards the edge of the bed, followed with the opposite leg. Then the patient would use their arms to push their upper body into a seated position. Once the patient is in this long sitting position, they can scoot forward to the edge of the bed until their legs are off of the bed. Technique A, or that first one that I talked about, should be used with patients that are having a history of back pain or surgery. That's the rolling. Or patients that have difficulty with pain should be using technique B, where they're scooting their leg to the edge of the bed and then sliding their legs down without rolling. A special consideration is required for all patients who have had total hip replacements. You should prevent the patient's legs from coming together at the midline at any time during the transfer. This is adherence to their total hip precautions. There are many different types of total hip surgeries today. Each physician may have different hip precautions for their patients. Now, a sit to supine transfer is just the opposite of the supine to sit transfer. This transfer is used when a patient would like to lie down in bed to complete exercises or to rest. For the technique A, that was the rolling technique, the patient should sit down on the bed near the head of the bed. The patient should lift their legs while lowering onto their side into a side-lying position. You may need to assist in moving the patient's legs onto the bed. The caregiver should stand near the bed for safety so that the patient doesn't fall off. The patient can then roll onto their back into a supine or lying position if they would like to be on their back. This technique should be used whenever technique A of the supine to sit is used, and such as patients that have had back surgeries or patients with chronic back pain. That's the rolling, technique A. Technique B, we will have the patient sit down on the edge of the bed, again close to the head of the bed. Next, the patient should scoot back onto the bed, lift their legs up into the bed, and the caregiver may need to assist the patient in lifting their legs onto the bed. Then the patient can slowly lower their upper body back into the bed. This is not rolling, this is just lifting their legs and then laying themselves back down. To review, there are two methods of getting patients into and out of the bed. Use technique A for patients with a history of back pain or surgery, and that's the technique for the patient to be rolling. It's easier. Caution should be used with all total hip replacements, and make sure that you check with a therapist and read the physician orders to make sure that you are correctly handling those patients. The patient's legs should never come together or cross during the transfer for those hip patients. Tub transfers vary greatly depending upon the type of tub, if there's a tub bench or a chair, if there's grab bars, if there's only a shower. So there's lots of different ways to do transfers. Often patients have a tub bench which comes over the side of the tub. Now this is something the patient usually has to purchase, so not all of your patients are going to have a tub bench. In this case, you would have the patient back to the bench, sit down on the bench with their feet outside of the tub. The patient can then lift each leg into the tub safely, into a seated position, and then they can have assistance for doing their bath as needed. Here are some general reminders that apply to all types of transfers. Always allow the patient to perform as much of the activity as possible. Only assist when necessary. This is an important part of the patient's rehab process and assists the patient in regaining independence. All patients may require occasional reminders for hand placement, leaning forward, or locking their wheelchair brakes. Remember, a gait belt can be used for all those individuals who are lower functioning and who might have a higher risk of falls. What should you do if you have a back injury? Well, you need to notify your supervisor immediately, even if it ends up being nothing. It is always better to be safe than sorry. You need to complete an occurrence report, and that would be an employee occurrence report. You need to seek medical attention. Most back pain goes away on its own, though it may take a while. Taking over-the-counter pain relievers and resting can help. However, staying in bed for more than 1 or 2 days can actually make your back worse. If your back pain is severe and doesn't improve after 3 days, you definitely should be calling your healthcare provider if you haven't already, and should get medical attention if you have back pain following an injury. So when should you decide to see a doctor for pain? Here are some signs and symptoms, and these are not all signs and symptoms, and it's not saying that you shouldn't seek a doctor immediately. These are just some common signs and symptoms that you definitely should consider seeing the doctor for. Numbness or tinglingness, severe pain that does not improve with rest, pain after a fall or injury, pain plus any of the other problems such as trouble urinating, weakness, numbness in your legs, fever, weight loss, even when you're not on a diet, or the weight loss is when you're not on a diet. You also need to learn ways to prevent future injuries. You need to protect your back by exercising after you obtain the physician's approval following any back injury. Here are some of the key resources that were used for today's presentation, and if you have any questions related to the body mechanics or transfers, please ask your supervisor and we'd be able to provide more assistance or speak with one of the therapists.
Thank you to listening to today's presentation on body mechanics, ergonomics, and MSD injury prevention. If you have any questions on anything presented in this session, please contact your supervisor or one of our therapists. Now please take the time to complete the post-test to complete this assignment.